Okay, everyone. So we are now going to talk about inflammation and the inflammatory response, acute and chronic, that we see in cases of injury. So inflammation is a protective response intended to eliminate the initial cause of cell injury, as well as to do a final cleanup for all the necrotic cells that are going to be resulting as the cleanup, as the neutrophils started to die, and they create this necrotic area with pus and dead cells, dead bacteria, etc. So inflammation is very much needed to heal, to cause healing, and to also clean up the area in the end, which is what I say exactly here. It is interwoven, so this inflammation and the regeneration that is going to happen is interwoven together. As soon as damage or injury occurs to the tissue, inflammation gets set in within seconds, and then as hours go by, new and different things start to happen. If there is too much damage, like the area is too much and complete regeneration is not possible, there is going to be a defect, a residual defect, which is a fibrous tissue, and that's what we know as scar. So most of the time, so depending on the nutritional balance of the animal, or if the animal is young or old, or the area, if there's a lot of vasculature. So for example, just as an example, injuries that are caused to the lower legs because there isn't a lot of muscle in the lower legs will tend to leave a scar, as opposed to injuries that, for example, happen in the barrel of the horse. So it just depends on the area, the nutritional status of the horse, and the age. Inflammation is going to help clear any infection, is going to make wound healing possible, but if it's not under control, it can actually cause more harm than good. So just as an example, when a horse has an anaphylactic shock, that is an exaggerated allergic reaction to something that it shouldn't react that way, and that can actually lead to death. So in that case, this exaggerated inflammatory response is not ideal. So acute inflammation starts immediately after an injury, and it is designed to deliver leukocytes to the site of injury. These leukocytes, which are the white blood cells, are going to come and they're going to clear any invading microbes, and they're going to begin the process of cleaning any necrotic tissue. The acute inflammation has two components. Number one is vascular changes, and number two is cellular events. For the vascular changes of acute inflammation, we're going to have an initial vasoconstriction. So the vessels are going to shrink in size. So there's vasoconstriction, so you can stop the bleeding. And then after the bleeding has been stopped, we're going to have a vasodilation. So it's the vessels increasing in size, so you can increase the blood flow to the area to bring in all the healing properties that the blood has. And then we have the cellular events, which is the second component of acute inflammation. And the cellular events are going to be the recruitment of different cells, white blood cells, and they generally start with neutrophils. But we're going to talk about all the different white blood cells and their role in inflammation. It is important that everybody memorizes the 5 cardinal signs of acute inflammation, which are heat, redness, swelling, pain, and loss of function. Those 5 cardinal signs are very important. And I know some of the things we're not going to be able to see. For example, if you have an inflammation of the liver, you're not going to be able to see the redness, but there is going to be an increase in blood flow in the area that is inflamed, and it would be red if we could actually see. But the redness we can actually see on our skin. But heat, redness, which is called erythema, heat, swelling, which is also edema, pain, and loss of function. And I need you guys to understand that it's not lameness, it is loss of function, because we're not just talking about exterior kinds of inflammation, we're talking about also organs and other tissues. Come back here. So leukocytes are the white blood cells And there is multiple leukocytes that are circulating in the blood. The one that is in the greatest majority is the neutrophils. About 60 to 65% of white blood cells are neutrophils, and they're the first response to any inflammation. Neutrophils, they engulf a bacteria and they phagocyte the bacteria or viruses or any microbial activity, and they die as soon as they do it. And they are the ones that form pus, which is a mixture of dead bacteria, dead neutrophils, dead cells. We also have, so neutrophils die as soon as they engulf and kill the bacteria. We also have granulocytes because they have granules, and they are going to be eosinophils and basophils, and this thing is having a delay. Eosinophils, they are going to be increased in size if the animal has a heavy parasite load, but they are also related to allergies. And the same goes for basophils. Basophils is very much increased in when they come to the area, they degranule, and there's going to be histamine in these granules, and they are also responsible for the allergic reaction that happens in the area. And as histamine is released in the area, histamine is going to increase the blood flow of the area, and that is what is going to cause the redness and the heat in the area. Lymphocytes are about 25% of the white blood cells, and they are divided into B cells and T cells. So lymphocytes are what we know as antibodies. Then we have monocytes. Monocytes, when it's the same cell that when it's inside the blood, it's called monocyte. And when it leaves, it goes to the tissue, it's called macrophage. So macrophages, they come in the end. They're also part of the antigen presenting cells. Macrophages and dendritic cells are going to present to, if you guys remember from the immune system lecture, that these are all part of the innate immune system, and so macrophage dendritic cells are going to recruit the adaptive immune system. So that's what we have. But macrophages they're actually the vacuum cleaner in the end, and they come and clean the entire area, and they can engulf multiple times and kill multiple times. So about the vascular and the cellular changes that happen in acute inflammation. So like I said, we're going to have an initial vasoconstriction to stop the bleeding. We're going to have platelet aggregation. If you guys remember the inflammatory cascade, we're going to have platelet aggregation forming that clot. And as soon as that happens, we're going to have vasodilation, and that is going to be responsible for the redness and the heat in the inflamed area. And the vasodilation is there so you can have more blood flow to the area to bring in the leukocytes so they can heal the area. We're going to have an increase in vascular permeability, if you guys remember from the immune system lecture. So these vessels, instead of having cells tightly packed around each other, there's going to be gaps in between the cells. And these little gaps, there's going to be fluid that can extravasate to the exterior, to the extracellular matrix, and to the tissue, the surrounding tissue of the vessel. And that's a protein-rich fluid. And that is going to be what causes the edema or the swelling of the area. Because we're going to have this increase in vascular permeability and this lymph getting out of the blood vessels, the blood inside the blood vessels is going to become more viscous, which means thicker. And the circulation, because it's more viscous, is going to slow down. And that enables the cells, because the blood is slowing down in that area, enables the cell to have more contact with the vascular wall, so they can actually roll. And I'm going to see here I'm going to show a little scheme. So they can actually roll and actually go out of the blood vessel to go to the tissue as well. So that enables the leukocytes to go to the tissue also. And that's what we call transmigration. So that's when the leukocytes squeeze themselves in between the gaps, and they transmigrate through the intercellular junction into the extracellular matrix, and they start to release chemical mediators to try to recruit even more leukocytes to the areas. These mediators are going to be prostaglandins, leukotrienes, histamine, cytokines, etc., and they will bring more leukocytes. Then we're going to have phagocytosis, if you guys remember. These leukocytes are going to engulf these injurious particles, and then is going to degrade them, and they are going to break them down, blast them with oxygen, and if they are antigen presenting cells, they're going to then present parts of these cells to the adaptive immune system. So this is just a scheme showing here normal tissue with arterioles, and then capillaries here in the middle, and then venules. And then in the case, so this is just normal tissue. And then in the case of inflammation, you can see how there's vasodilation that has happened in the area. There's many more leukocytes on the extracellular matrix. There's going to be more protein, which is depicted here as this little curly guys, which is fibrinogens, etc. Okay, so this vasodilation that happens here enables more blood to arrive to the area, and then the lymph leaving the area through the gaps enables this transmigration of the leukocytes into the extracellular matrix, which is depicted in this graphic right here. So we're going to have these are just neutrophils, and they are rolling around, with the flow in the veins, and then they roll close to the vasculature wall, and they roll, and there is adhesion that happens. They glue themselves to the area, and then they squeeze themselves outside of the vasculature to go to the site of injury to start the healing process. There is pretty much 3 outcomes of an acute inflammation. The number one is resolution, which is when the injury is limited, short-lived, there is minimal tissue damage. The tissue is going to be capable to replace any dead cells, the ones that died, and they're going to be replaced with perfect and functional cells. And if it's minimum kind of injury, not even a scar is going to be left, which is something that happens to us all the time. Little cuts, there isn't even a scar that is left behind because complete resolution was achieved. The second outcome is going to be scarring or fibrosis. So if the tissue damage is too large, or if the injury is too prolonged, so then there's going to be scarring of the tissue. So scarring is pretty much the body's trying to regenerate, trying, and then it kind of runs out of resources, and then it just starts to deposit fibrotic tissue. When it deposits fibrotic tissue, it is a form of healing because the area is now closed. However, that fibrotic tissue doesn't have the same properties as the original tissue. So for example, in the skin, the fibrotic tissue, which is the scar, is not as tensile, is not as plastic, is not as elastic as the skin, but it does have the purpose of getting that skin closed. So that's what happens also in organs, and that's what happened in skin, etc. So that generally happens when the tissue damage was more substantial than the body was capable of healing. And then it can also progress to chronic inflammation. Chronic inflammation can become a problem because there is tissue being healed and tissue being destroyed at the same time. Examples of chronic inflammation is, for example, tuberculosis, which is a long-term bacterial infection of the lung, and there's going to be so much damage in the lung. Also, arthritis, so like arthritis of the joints. A lot of the times, if older people, when they have chronic arthritis or even rheumatoid arthritis, there's going to be tissue healing and tissue damage happening at the same time. In cases of chronic inflammation, you actually need anti-inflammatory drugs to tone it down because the inflammation is what's actually causing more damage than healing to the area. And that's what I say exactly here, is that chronic inflammation is considered inflammation of prolonged duration, and there's going to be active inflammation, healing, and also everything happening at the same time. There's going to be tissue destruction at the same time because the inflammatory process is a little bit out of control. So that's when you need to tone it down, to try to bring it back to healing or to try to live in a balanced way. Chronic inflammation may lead to repair and not regeneration. So there's a difference. So regeneration is when the tissue is completely healed back to normal 100%. Repair is when regeneration is not possible. So there is fibrosis in the area. When there is fibrosis in the area, that's called repair. So like I said, things are closed and things are, looking more or less normal, but it's not the same. Fiber is not the same as the original tissue. Regeneration is going to mean that the tissue is perfectly just as new morphologically and functionally, and repair is going to look okay, but it's going to be fibrotic tissue. Chronic inflammation is going to come from persistent microbial infection or prolonged exposure to something toxic. For example, when people that work in the coal mines, they are all the time being exposed to toxic agents. Autoimmune diseases like multiple sclerosis, etc., is going to lead to chronic inflammation. So this here is the photo of a lung that has what we call caseous inflammation here. So the reason why it's called that is because it looks like cottage cheese, and that's what tuberculosis is going to lead. This seems to also be a lung of a smoker. That's why it's dark like this. But this right here is like a tuberculosis infection that is this cottage cheese kind of inflammation. So the tuberculosis, not only does it take a long time to form, it also it's going to take a long time to heal as well. It's like 6 to 9 months of taking antibiotics to be able to heal completely. And once you can imagine, anytime that you have an abscess, by the way, which this is an abscess, this is a bunch of bacteria encapsulated. Anytime that you have an abscess, you're going to have a scar in the end, because it's abscessation, which is a collection of pus inside a capsule. This abscessation, the body goes into a lot of trouble to actually make a capsule around it. So then it leaves a scar in the end. So this is going to be a schematic again of, this is when we have injury that is going to lead to acute inflammation, or that's going to lead to chronic inflammation. So we have this injury, and it can be anything: trauma, bacterial infection. We're going to have vasodilation to the air, neutrophil recruitment. We're going to have the release of mediators that will lead to resolution, which is this guy here. Or if it gets infected and forms into an abscess, you can see abscesses have a ton of white blood cells around. There's disruption of the blood vessels, and abscessation can heal, but anytime that it heals, as you guys can see, these little curly guys here is depicting fibrin and fibrinogen and just fibrotic tissue. So anytime that you have an abscess, you're going to have, the result is going to be fibrotic tissue. And then here is when you have chronic inflammation, you're going to have a lot of angiogenesis happening, which is the formation of new blood vessels. And generally, chronic inflammation and a lot of angiogenesis is going to lead to scar as well. But sometimes it can lead to regeneration, but it's more often to lead to scar. What is important to understand about this healing process that is happening is that the extracellular matrix, which is this tissue that is extracellular outside of the cells, is going to critically regulate the growth, movement, and the differentiation of cells. What does that mean? That means this. The body starts as like 2 cells, right? So as the body progresses, as the body then later on differentiates between what is skin of the face, what is eye, what is nose, what is cartilage, what is articular cartilage, what is muscles, what is cardiac muscle, what is GI tract, etc. It is the function of the extracellular matrix as injuries are happening to be able to know. So if you injure your liver, it is the function of the extracellular matrix to actually deposit again hepatocytes, as opposed to depositing an eye into the liver. So you guys can see how complex this whole thing is, because if you injure your eye, it is also the function of the extracellular matrix around the eye to actually deposit eye compatible tissue, as opposed to skin. on your eye. So just so you guys can understand the difference, because the hepatocytes have one type of function as opposed to, say, the GI tracts that have other types, such as digestion and absorption of nutrients, which hepatocytes don't do that. So each area is going to depend on the extracellular matrix to regulate the growth, movement, and differentiation of cells. If you guys remember when I was talking about the mucociliary system, these cells in the trachea, so you can just imagine if the cells, instead of having the little cilia turned up, if the extracellular matrix turned it down, it would have zero function. So that's the importance of the extracellular matrix. It also is going to confer mechanical support for this whole area, and it's the extracellular matrix that has a lot of proteins, collagen, it has all this tensile strength, it has recoil, it has elastin, it has glycosaminoglycans, it has hyaluronic acid, etc. So it's the extracellular matrix that confers this tensile strength to the tissues. And it's you all know, as people age, they start to create wrinkles, and it's because the extracellular matrix is getting older and older and older, and also because collagen and these kinds of protein are only going to have so much life in their life. So that's why you start to have less and less turnover, and that's how wrinkles are going to start to develop. So here is just showing, it's just a graphic of the extracellular matrix that you can see some cells of the epithelium here. Blood vessels are going to be here. And then we have the extracellular matrix happening here. There's going to be all sorts of proteins. There's going to be fibroblasts. There's going to be elastin, collagen, proteoglycan, hyaluronic acid, etc. Okay. So when the injury is a little bit too big and the body is not going to be able to totally regenerate the area, we're going to have repair by connective tissue, okay, which is going to be called fibrosis. That's because of severe or persistent tissue injury. If you guys remember what I talked about, alcoholism and the daily drinking of alcohol that is going to be damaging the liver slowly and slowly. The liver has a way to regenerate itself, that it will continue to regenerate until it gets to a point that it starts to deposit fibrotic tissue. And that's what I was talking about when I talked about that, is that this fibrotic tissue is going to allow the liver to have some sort of form, but the cells are not, there's not even cells. The hepatocytes are going to be dying, and they are going to be exchanged for fibrotic tissue. So that's one of severe or persistent tissue. So that would be persistent tissue injury. Severe would be the example that I gave, was binge drinking, that it's way too much for the liver at that one time. A lot of the times too, we're going to have, depending if we have some sort of infection or if we have large area being that has been injured, we're going to be able to see more or less the formation of granulation tissue. So granulation tissue is extremely important for healing. It's impossible to have healing without granulation tissue. Okay, so that is a given. So granulation tissue is incredibly important for that. So it's when every time you have a cut and you see a little bit of like the new tissue, and then you change your band-aid or whatnot, and that glued to the band-aid, and you remove and you start to bleed again, that means that you just removed the newly formed granulation tissue. The importance of this, guys, because it has a lot of new blood vessels, so angiogenesis is very, very important. The reason why is it important? Because you're bringing in more blood to bring healing. And the reason why it's so easy for us to remove it with like even a band-aid is because it has a very loose extracellular matrix. It is pink, it's soft, it has a granular look to itself. Granulation tissue is highly populated with macrophages. So that makes them very they don't get infected very easily. So but they can get infected, but it's not very, very easily that they are going to be infected, because they have a lot of macrophages that will just continue to kill any bacteria or any kind of microbes in the area. When you have a lot of granulation tissue being formed, you're going to have a bigger scar in the area. Now, when you have, so in horses, we have types of granulation tissue that can become what we call proud flesh. And the reason for that, in the lower legs of horses, where we don't have a lot of musculature and not a lot of blood vessels, then we have proud flesh being formed there, and you have to be careful with that. And every once in a while, we have to excise that proud flesh, because wounds can only heal, and this is important, wounds can only heal if the borders of the wound are taller than the middle of the wound, okay? So they can actually get approximated. If the borders of the wound are lower, so if you have proud flesh, like a granulation tissue that is above the borders of the wound, then there is that mechanical barrier impeding the wound to actually get approximated and to close. So when you have proud flesh or exuberant granulation tissue, you have to excise it. And that, depending on the horse, you're going to have to do multiple times. So you can lower the center of the wound, and you can revive. So there is like all sorts of debridement that you need to do to try to revive the borders of the wounds to make them approximate to be able to heal. Because here's how it works. So the body, the extracellular matrix, only deposits cells when it can, if there is space. So if there is not space, if there is this mountain of granulation tissue, the extracellular matrix doesn't allow to deposit more cells. And that's the difference between normal cells and cancerous cells. Because normal cells, when they have a physical barrier, they stop growing. So remember I talked about apoptosis, the cells dying and regenerating themselves. If cells didn't stop growing, we would just continue to grow without any regulation. And that's the difference between normal cells and cancerous cells, because cancerous cells, they will have lost this power to stop growing. So they hit the wall of something, or they hit a barrier, but they continue to grow. And that's how you get masses, gigantic tumors, because they continue to grow without stopping, which a normal cell, normal tissue would stop. There's going to be, so for wound healing, it's a very organized event. It starts as soon as the wound happens, as soon as the injury happens. There's going to be, we're going to have mostly in equine medicine, we're going to have two ways to heal wounds. The number one is by first intention. And by first intention is anytime that you have a surgical wound, or you have a wound that you're able to approximate and suture without it being infected. So any wound that is more or less, generally, if it's a clean wound, 6 hours or less, you can actually suture and approximate the edges of the wound. And if it's contaminated wound, say for example, even if it happened 6 hours ago or less, but it's full of manure and dirt, it's going to be a little bit more problematic to try to approximate, because you're going to have dehiscence, which is when the stitches just open up and you have a lot of infection. So first intention is there is minimum scarring forming. The edges of the wound can be easily approximated or not, even if not the whole wound can be approximated, at least the majority of it. And it's going to maintain, the tissue maintains normal function, and the scar is going to be minimum. By second intention is when the wound heals from the inside out. So it just leave it open and it heals until the body deposits a little bit of scar in the end. And that's why I say here that fibrotic scar is the result, and it may be bigger or smaller depending on the location, depending on the individual. Okay, but a lot of the times normal architecture is not going to be achieved, and you may have like a lot of granulation tissue that you have to excise, etc. Wound strength. So wounds that have been sutured, at the time of the suture, they're going to be about 70% of the normal strength of a tissue that hasn't been injured, when the sutures are removed, that strength of that wound, so the probability of it opening up again in case of a re-injury, the wound strength of at that point is only about 10%. And then at the end of 3 months, the wound is going to be, the strength is going to be about 70 to 80% again. So it's not that the scar is not strong enough, but it is, but it's not as elastic as normal skin would be. It is more, it's a little bit more rigid. So this is what I had for you about acute inflammation, about extracellular matrix, about scar formation, and what leads a body to go to regeneration as opposed to repair, what leads to chronic inflammation, and how microbial infection. This is important because anytime that you have microbial infection, healing cannot occur if you have microbial infection. So anytime that you have an abscess or anytime that you have an infection, healing cannot occur. And that's why antibiotic therapy, which we're going to talk in the next few lectures, is important in certain cases, so you can actually kill all the microbes in the area so healing can actually occur. So it is important for you guys to understand that. And if you have any questions, don't hesitate to contact me. And the next lecture, we're going to be talking about anti-inflammatory medications and then antimicrobial medications.